It's my job as the moderator to keep us on time and say as little as possible. You are here. Here's where we are in the agenda. We are teed up to begin session 3, and it is my pleasure now to introduce, and I think she's here. I'm over here doing the same thing a lot of you are, sort of navigating and toggling what my view looks like, since we're only in this pretend room testing mics and moving things around and getting coffee in the back of the room and then grabbing our seats to start this third session. But I would love to introduce all of you to Noemi Diaz Burgos, who has been an intern with HFA, who has served as an advocate, a very active advocate on behalf of the community on issues that impact all of the issues that have been raised today, but issues that impact access and safety and cost and affordability. So thank you to Noemi for offering to be session 3 facilitator. I'm going to pass the mic to you and let you get us started.
Thank you so much for that intro, Mary Catherine. First, I want to confirm everyone can hear me okay? All right.
You
Awesome.
sound good to me. I see heads nodding.
Great to see everyone. So as Mary Catherine said, I am Noemi Diaz Burgos, community member and advocate. I'm also a member of HFA's Health Equity Council and have been involved first through my brother who has hemophilia A severe, and then later on through my own diagnosis of hemophilia A mild. It happened maybe 2 or 3 years ago, but a lot of that came because of the advocacy behind it, right? So it's my pleasure to facilitate today's summit. It's called Communities of Concern: What are the costs of these unmet needs, right? And this session is designed to look closely at the voices in our community that aren't always fully represented or amplified in, this broader landscape that we've talked about today. And it can be including, but not limited to, women and girls with bleeding disorders, as well as the Black and Brown communities within our bleeding disorder community, who are often evidenced to face extraordinary disparities in the healthcare system, barriers to care, and can be exacerbated by the kinds of barriers that we talked about earlier today. So I want to encourage everyone to speak up. We have the chat option for Q&As if you would like to submit a question. And I just want to go ahead and start by introducing today's amazing panelists. So we have Lisa Littner, MPH, MSW, all the wonderful qualifications right there you can see on your screen. So she is a Hemophilia Treatment Center program manager over at the Cincinnati Children's Hospital Medical Center. So that's awesome. We have Helen Lamping, Executive Director from the Tri-State Bleeding Disorder Foundation. We have Rigo Garcia III, love that, Executive Director for the Hemophilia Foundation of Southern California. And one of my personal favorite people ever, Mosey Williams, clinical social worker, UCSF Adult Hemophilia Treatment Center, and hemophilia community member, and also a collaborator on the project Healthcare While Black. Last but definitely not least, we have Dr. Jill Johnson, hematologist and physician, who's been treating people with bleeding disorders in Washington State and the Pacific Northwest for most of her career. So thank you to Dr. Johnson as well for always contributing your time to answer the questions that we have from the community. So I want to pass it over to Lisa and Helen to get us started.
Thank you so much, and we appreciate HFA asking us to speak today about our Women Bleed Too outreach project. I'm Helen Lamping, and I'm the Executive Director of Tri-State Bleeding Disorder Foundation. I'm going to pass it to Lisa.
And I'm Lisa Littner, Program Manager at Cincinnati Children's Hospital's Hemophilia Treatment Center, and I'm also on the Board of Directors at the Tri-State Bleeding Disorder Foundation with Helen. When we started to consider developing this program, Women Bleed Too, we wanted to kind of further identify the needs in our target population. And so we wanted to just share some data in the research about the needs. So 1/5 of women experience heavy menstrual bleeding, and among those, 1/4 have a bleeding disorder. Many women with a bleeding disorder are not diagnosed until adulthood, even though they have symptoms as a teenager. Research has shown that it takes the average woman 16 years to be diagnosed with a bleeding disorder. Women face a lack of access to care. Many medical providers lack knowledge and training about bleeding disorders, and they aren't familiar with guidelines of care. Women face misunderstanding and an under-recognition of symptoms. Many women aren't familiar or understand what a normal period is. Many medical providers, when they're presented with symptoms of, or presented with a woman that has symptoms of heavy menstrual bleeding, they don't, or are familiar with the guidelines to know that it might be an indicator of a bleeding disorder. Women can experience variations in their symptoms. Women can experience variations in their clotting factor levels, and all of that can contribute to a delayed diagnosis and under recognition. Next slide. And so we collaborated with the University of Cincinnati in Cincinnati, Ohio's Adult Hemophilia Treatment Center, and with TriHealth Hematology, an adult healthcare system in Cincinnati. We applied for funding with the Hemophilia Alliance Foundation to support our programs. So we wanted to give a special shout out and acknowledgement to the Hemophilia Alliance. The goal of our program is to increase the knowledge and understanding of bleeding disorders among obstetricians and gynecologists in the greater Cincinnati and Northern Kentucky area. Next slide.
So these are the steps we took to get started on our program. The first step was to identify 9 local OBGYN practices with a total of 95 offices, and included 360 providers in the greater Cincinnati, Northern Kentucky area. We also utilized an all-Ohio OBGYN provider list, which was great because it provided provider-specific email, and I didn't always just get the office manager when reaching out with our materials. We created evidence-based education to help identify and treat women with bleeding disorders. This included information from the Foundation for Women and Girls and the CDC. We also assembled a list of hematologists that patients could be referred to. We had cookies made with our logos and QR codes that linked to all of our education. So exciting. That was the best part of the project. Emailed a description of our program along with the educational resources to all the identified practices and providers. And we ended up dropping about 25 educational packets with goodies to those groups who expressed interest. We provided breakfast to 5 of these practices and stayed to speak about the program. We offered in we offered in collaboration with HFA and the CDC a CME program, Project Echo, to all OBGYN providers. It was a series of 4 one-hour presentations. It started in August and will wrap up this coming Monday with the 4th in the series. The topics included how to screen for a bleeding disorder, testing for a bleeding disorder, iron deficiency, and building a bridge with specialty care. Building a bridge with specialty care is the one that will be taking place this coming Monday. We also offered a CE to NPs in the OBGYN groups with the article Heavy Periods and Bleeding Disorder Evaluation in Adolescents from the October 23rd issue of Women's Healthcare with NPs. We prepaid for 30 NPs to take this CE. As part of this program, we also hosted a physician's dinner for OBGYN providers. Dr. Eric Mullins and Dr. Leslie Breach, both from Cincinnati Children's, spoke about their combined Heme-Gyn clinic at Cincinnati Children's. This is one of the first of its kind in the nation. And then we also had Dr. John V. Galamudi from UC's Adult Treatment Center, who spoke about women with bleeding disorders during pregnancy. And then as part of our outreach, Dr. Christine Karkoska, who's the acting director of UC's HTC, spoke at the OBGYN Grand Rounds at UC in June. Now, we can do the next slide. So this is just an example of our resources that we used. The first page is our list of referring providers, the list of hematologists along with some bleeding disorder facts. The second page is links and a list out all of our bleeding disorder resources along with QR codes that link to those. The top right is a picture of our cookies. And then the bottom is a picture of our total packet that we had put together. So how we evaluated success, or how we will evaluate the success of our program since it's ongoing. We're going to track our click-throughs on the QR codes linked to our education. We'll track the number of participants for the free CE for NPs and also the Project Echo CME program for all providers. And then the University of Cincinnati's HTC and TriHealth Hematology have agreed to track and compare the number of referrals received from each OBGYN group 6 months before the start of our project, and then again at the end of the year to see what kind of progress we've made. Next steps that we're looking forward to once we wrap up with the OBGYN outreach would be to reach out to other groups such as anesthesiology practices, surgery practices, and dental practices as well with this information.
And then these are our references. And then some of you may have seen in the chat, the link to register for Project Echo that is on Monday. And you can also scan this QR code. We'd love if you could join our last session. Next slide. And then these are our email addresses. We're happy to send you our resource list and our kind of educational tool with the different links on it if you would like. And you can also visit the Tri-State Bleeding Disorder Foundation's webpage. There is a section for Women Bleed Too, where you'll find a lot of our educational resources as well. Thank you so much for the opportunity to speak. And now we will pass it on to Rigo and Mosey.
Thank you so very much. My name is Rigo. I'm the Executive Director of the Hemophilia Foundation of Southern California, and I'm here with Mosey.
Mosey Williams, social worker at UCSF Adult Treatment Center, and also a board member for the Hemophilia Foundation Northern California chapter and Hemophilia Council of California chapters. Council, thank you.
Yeah,
and
go for it, Mosey. No, go ahead.
I was just highlighting the first slide. We were able to work together. There were two efforts that we want to highlight in this part of the presentation, two outreach efforts. One we teamed up on, and then one that was through the chapter that Rigo heads up down in Southern California. So the first outreach effort is Healthcare While Black. Go ahead, Rigo, sorry.
Yeah, no, and I think one of the biggest things with this was that, when we touched base with Mosey, as we're looking at Healthcare While Black, we actually had an event here in Southern California, and I had an African-American family come up to me and let me know, they're like, Rigo, you have events taking place for a lot of different community members, for the Latino groups, you have Spanish programming, but we don't really see people that look like us at our events. And what is it that we need to do, or what is that? How can we improve this? And so this was one of the things that, as we were looking at this, reached out to Mosey, having worked at a Northern California chapter, and then also just working throughout the US. How can we improve this information? And so when we sat down, we really wanted to kind of take a different approach to it. And so this is where we started to we came together and we concluded that we were going to have a panel discussion and being able to discuss Healthcare While Black. We had two community members, myself representing the chapters, and then Mosey from his background and expertise, but also being able to run the panel. Next slide. Did Mosey want to talk a little bit about it?
Sure. And, and coming into this effort, we had support from Ayanna Woods of Bayer, and we all were able to have a discussion about the African American community. And so what we wanted to do was look for leaders in the hemophilia and bleeding disorder space as well. And so our two panelists, Chelsea Nabrett, who was an NYLI member also and spoke for NBDF, and also Brandon Young, Country Boy Fishing, and he's done work in the community as well. So both of them are leaders. And myself as well, having spoken at NBDF. And so looking at our own experiences was one part of it. Outside of this, before I became a hemophilia social worker, I worked with a nonprofit called Conscious Voices, which provides mental health services for the African American community. And so having that background and seeing where needs through needs assessment, seeing things that can be provided, what we're asked for, and I think that's the key with all of our communities. And we're here looking at the rural space and the needs that aren't met. And we're not going to always get it right. We're going to overlook things. We're human. But the key is that we lead with the heart. And when we make a mistake, we acknowledge it. And so just as Rigo described, a family that came up to him, we don't always see the blind spots, but once it's brought to our attention, okay, now we can highlight this and what can we do to provide support to this area and reach the needs that are being presented. And so for us in this effort, having our own experiences as patients, being maligned due to race, myself as a provider has happened as well, and also as a patient. And so we were able to talk about these experiences in this safe space that I was able to help with, and Regal cultivated as well. And so looking at what we learned and then how to respond to that, and then how to support other people going through it, and what are some things that we can do for our patients. And so starting with this awareness. So now we have the awareness because it's brought to our attention. This space was also a voice. And so for those that were able to view it, can see, okay, they have had these experiences. They have supported others through these experiences. In the least, these are people in our community that we can share with when we see them. And they're looking at solutions and talking about things. So this is starting that conversation as well. And then allyship in terms of how can I come along somebody else that's going through this, or whether or not I look like them, or if I look like them and have not had the experiences they have had due to privilege or otherwise, or just not being in certain areas. And so when we think about that, we were able to do all these things in providing this 45-minute space, and we wanted to do so that people could see it during their lunch hour, and it's also available on YouTube so they can go back and revisit it.
Right, and that's one of the things that when we were really focusing on, we kept it under an hour so that it could be like a lunch and learn with different treatment centers, different just services. And I think one of the biggest things that we found is that for us, many times it's easy for us to try to find someone to translate the information into Spanish because we want to hit the Latino community, but we really don't talk about some of the issues that many other groups are going through. It be African Americans, it be Asians or whatnot. When we started looking and focusing on our African American community, we both found out from Brandon and Chelsea just their experience at a hospital. Chelsea had never taken any type of pain medication. Young African American woman. She takes the medication and has a difficult time with the nursing staff in the sense that they're making fun of her because she doesn't know she's hallucinating, which is some of the stuff that happens with the pain medication that she was in, and she had just been in a major car accident. So not only was the pain and the trauma from the car accident she had gone through, but then going through this, which was very difficult. And Brandon, he was in some pain. He was at the hospital, and the nurses told him, "We're not a drug dealer, so don't ask us for any drugs." And this is the stuff that we sometimes don't realize, that words have power. And for many of the communities, the communities of color, many times we forget this, or we don't realize it because we haven't experienced it. And so this is one of the reasons that when we're talking to them, we always overthink. And I think both Chelsea and Brandon told us it's not difficult, Rigo. Just try it, see how we learn. And I think one of the biggest things from my background being a health educator is that when I provide health education classes, we provide them in so many different ways. Just like, I like to correlate it to religion. If you go to a Latino religion group, they're listening and doing it one way. You go to an African church, African American church, and they're going to be very active, very vocal, and this is how we have to think about when we're working with our communities and how we present programming. An African American community or Latino community is not going to stay still and go through all your slides then answer questions. They're going to be jumping in throughout the whole process, and you have to be ready for that and know that they're not being rude. It's just the culture that we are. We're involved from beginning to end, and that's not putting any other culture down. It's just how we learn. And I think that's one of the things that when we're creating programming, we really need to make sure that we're including some of this in there. Next slide. I think we jumped into a couple of them, but
Yeah, and I'll just say lastly to add to that, the cultural context is important, and we can ask questions. Okay, what kind of programming would you like to see? What would be helpful for you? And a lot of times there is acknowledgement, and then just taking step beyond that. Like the shirt I'm wearing today it's Beyond 28. This is Golden State Warriors. I'm a Warriors fan, but they handed out shirts at one of the games and acknowledging the effort that we have Black History Month. We have different heritage months. February is Black History Month. It's 28 days, but we want to go beyond 28. So because the lives extend beyond the month of any of the groups that we acknowledge. And so it's not just checking that box and moving on. It's how do we continue to support all groups after the spotlight is on them culturally and in society. The needs are still there, the support is still needed. And so continuing from there, and then now into looking at the outreach effort Familia de Sangre.
Right, and I think that's one of the things that we've learned, in California. The 4 chapters in California have come together, and we host Familia de Sangre, which is the national all Spanish conference that takes place. This past year, we had over 700 community members, and all of our programming is in Spanish. What we're facing, what are the issues, and we have so much. Positive outcome, positive feedback that we get through our communities, because it is families that are coming together that look alike, that are going through the same programming. Now, what we want to do and learn from this same thing that we did with Familia de Sangre is how can we do this with the African American community? How can we start this small? How can we then start creating a program or a toolkit? And that's kind of our next steps with Mosey and I is how can we start packaging this so we can start sharing it with other chapters and other organizations? And we are talking to our national organizations to be able to see and to give us space within their conferences, and not so much just to talk, because we already have sessions that are taking place, but how do we take it beyond that? And what are the needs that they need? And one of the biggest things that we've learned, not only within the panel, but is not be afraid of whatever answer you get back, and being able to move on that answer. It might not be pretty, but I think one of the biggest things that is, if we want to make a change and make a change within any type of community, it be the African American community, we're talking here rural communities, the Latino community, you have to be open to listening to what they're going to say, and then be able to move next steps in whatever you hear from those answers.
Right. And not taking the information personally. And I think it's sometimes like when the feedback does come, it's easy to get defensive, but then the work doesn't get done, because then I'm defending my ego about why I felt like my program should have served Black people in a certain way, for example. I'm not going to get it right because I don't have the experience of everyone that's Black or any other group that I'm working with. So I have to be able to sit back and say, okay, I understand what you're saying, listen to it, and be able to make changes and take the constructive criticism. And that's how we all grow.
I think that's our last slide. Yeah. And so one of the biggest things that we would say is that as we get this, we're not giving voice to the African American community because they already have the voice. What we want to do is we want to start to create a new platform within the national organizations and the local chapters. And one thing we would say is that if anybody is interested in joining us, Mosey and myself, to try to start to create something, to try to get something out, even if it's a rough something, for February, which is a really great platform. It's beyond the 28 days, but a really great way to start this process within 2025. Please let us
Yes.
reach out to us, and we'll be more than happy to try to create something and put something on the calendar for us for 2025.
Mhm. And I will say, in terms like when we think about not being able to, I can't speak for any all of a group of people that may look like me, whether it's hemophilia, whether it's ethnicity or what have you. And another part of that is the intersectionality. And so we cannot assume that just because, okay, if I tell these people in this way that they'll all get the information, or and so one part of that is the rural aspect, or maybe not even rural, but just access that limits sometimes as well in terms of technology. And this is something that my work with the chapter as a board member, we had talked about with HFNC, was that we're sending out emails, but that's not necessarily accessible for everyone, whether it be literacy, whether it be technology, access to certain technologies. We can't assume that. So we may have to do other ways to reach out in terms of phone calls, and it's a lot of work. I mean, making personal phone calls, if we're not doing a robocall, we may have to call specific families and take the time to do that to reach them. Some people don't listen to voicemail, or they don't read text. There are different things. So we may have to take different steps in order to make sure that they do have access to the information. Or sending snail mail outs again. I know that in some ways we had stopped doing that because we're sending emails and it's cheap, right? But sometimes we have to take another step to reach those that we aren't already reaching through the means that we're using. Next, yeah. Any questions or comments?
Awesome.
Thank you.
So I think this is where I hop back in. Thank you to all our panelists. I definitely love the idea of QR cookies. That's actually so creative. I have like so many ideas where I could take that. And also thank you, fellas, for telling us about, intersectionality and just reaching out beyond what we usually think. So we do have some questions in the chat. We also have some questions that were pre-selected. So feel free to add your questions in the chat. But to start off with, my first question is, to the panel in general. In your view, what does representation, both among healthcare providers and within advocacy organizations, play in addressing the unique needs of women and people of color in this community?
I think if we want to stay relevant overall with the community is changing, and in regards to treatment centers, of course, the bleeding disorders community is always gonna need them. But I think having representation and people that look like them having representation that are going to understand them, then I feel that people are more willing to go for treatment, and continue it. So many times we hear that, what is it, 60% of the bleeding disorders community attends a treatment center. Well, where does the other 40% go? And sometimes we could connect with them, and many of them don't come back because they had a bad experience, or they'd rather just chance it. And that's something that's very important in regards to making sure that our community stays healthy. Now, with the organizations like ours, one of the things is that if we want to continue to stay active and be part of the community, we have to continue to evolve with it. And we're no longer doing just hemophilia 101. But what we need to start to do is we need to start changing the programming that we do that is connecting with all of our community. And that community is going to be very different depending on the geographical areas that we service, the communities that we service, the races that we service. And I think one of the things that we need to make sure is, as things are tough right now, and we're seeing that with a lot of people of color, is that we need to make sure that they do not feel that they've been forgotten, or that we do not care for them. And I think this is why it's important to continue to provide programming that is focused on specific races.
Absolutely. So kind of as a follow-up to that, what are some examples of programs or resources that have successfully addressed the needs of these communities? I know that Project Echo was mentioned, as well as Conscious Voices, which I definitely want to follow up with myself after this. And, you know, in addition to that, what made these initiatives effective and what gaps still remain?
Well, I think it's important to get the information to the OBGYN community. I think hematology is a rare disease. You know, not all medical providers are aware of specifically what hemophilia is or what a bleeding disorder looks like. It's even, and it's always thought of, I think, as a male dominant disease. I think most people know of hemophilia specifically, and they think it's they look for it in men. But I think, you know, with women's symptoms, especially menorrhagia, those types of things, women are used to bleeding and they're used to being dismissed because of these reasons. So it's really important to empower women with the facts. And then also the other end is to educate OBGYN providers that this does exist, that this is, there is a need for education and information.
Great points. And actually, it was my OBGYN who helped me get my diagnosis.
Mm.
So there are some really great OBGYNs out there. I met her through a summit and a conference we had here in Florida for women. And yeah, just shout out to them and just continuing to educate them as well.
Yeah, I'd like to add, I've spoken with a lot of really great OBGYN providers, and I don't want to dismiss all of them as not being
Right.
knowledgeable on bleeding disorders. There's just a vast, there's a majority of those that don't know. But speaking in a lot of these groups, a lot of these physicians would come up to me and say, ah, what about this? And they were very knowledgeable. So I don't want to write them all off.
Absolutely.
Yeah.
Yeah. And so, to that note, I know we've talked a lot about different needs, different actions that can be taken during today. But I want to ask the panel, what are some key changes, either in policy, education, community engagement, that you believe would improve healthcare equity for women and people of color with bleeding disorders?
Related, kind of adding to what Helen was saying with the increasing awareness to obstetricians and gynecologists, I think just a really small tangible way is just increasing awareness about some of the screening tools that are available. There really is a need for you know, OB-GYNs and then others in the community to do more of a deeper family medical history and a more detailed medical history related to bleeding and related to heavy menstrual bleeding. And then even one of the pieces of our program that we did once was having the hematologist speak to the residents at University of Cincinnati's medical school. But if there could be a way for that to become more regular and to have more of an emphasis during the training years, I think it could be really impactful.
To piggyback on that, and someone put in the chat, education of closely associated professional organizations. And I think in terms of advocacy, we have advocacy where, you know, we have legislative days where we can go to the Capitol. And so we have our patient population who will go and present and talk about having a bleeding disorder. And we have women with bleeding disorders who have done that. But thinking about that, maybe we need to do so for for our providers as well. Like maybe there need to be presentations. And we have that here at our HEC where we'll present to different departments on campus, whether it's dental, and explaining about what hemophilia is. But maybe we need to have, for example, women with bleeding disorders presenting to different hospitals to be able to say, if someone was comfortable to say, I have a bleeding disorder, I am a woman. I know that it's been, you know, stereotyped and assumed that women do not bleed, but we do, and I'm an example, and so on and so forth. Maybe there has to be that to break these stereotypes and assumptions that providers have.
No, I'd love to piggyback into this as well. So as from both a provider and then also I do research, is that we need to promote all these wonderful efforts and awareness and education, and then we need to lower the barriers to the next step, which is getting to a diagnosis. Because once you have the diagnosis, then you have the key to a system that's not ideal, but without one, you have no keys to the system. And the laboratory aspect of that really has a lot of high barriers, especially when we need genetic testing or specialty labs. And that particularly, I think, impacts the rural community where they may have to travel, or there's a lot of barriers to getting these approvals. And part of the question was around policy. So I think that's one place where advocacy can probably do a lot to try and lower these barriers for all these insurance denials we see, for example. And another example would be like program changes, programmatic changes that identify the needs and try to lower those barriers generally. And then lastly, we can't improve this without evidence. And the rural population that's impacted by bleeding disorders needs to be represented in our research if we're going to get the evidence how to make things better. And so I think it's a general need, but where policy could help is if we can get to the diagnosis, then they can be more likely to be represented in the system.
Right. And I think that one of the biggest things with that is that when we're talking about rural communities, that's one of the things that even like what Helen was doing, which is amazing. And Helen has spoken she's presented it to some of the executive directors in the past. And I think this is really important because we're trying to see how can we, copy her and be able to do this to non-HTCs. Where are these rural patients going? And I think those are the doctors that we need to start reaching out to, kind of taking a step further. It's not just the big OBGYNs or the big HTCs going through them, but when we're talking about communities living 3-4 hours away from a treatment center, where are they getting their care? And those are the areas that we need to focus on and be able to provide that education. And that's where I feel many of our chapters like ours can really get involved to assist in that aspect.
Yeah, I'm going to get into that as well. So that is absolutely key, is that people are isolated on the provider side, on the community side, by lots of things. Their social constructs, their geographic location, any number of things may make them inadvertently isolated. And you add that with the rare disorders, and then they're just alone. It's the only person that provider's ever seen with that diagnosis, et cetera. So in the state of Washington, the HTC partners with local hematologists to help them, because we can't be everywhere. But we can help the local hematologist as sort of a super subspecialist. So I think that's one potential model for the providers, at least, to not be alone either. We need them not to be alone.
Yeah, I actually want to add a little something and address a comment that was made, because one thing I'm noticing, and I think our doctors, we kind of have to meet them where they're at, right? We have this idea sometimes that doctors know everything. I'm in academia, and the same thing happens with professors. And then you kind of realize they're just humans as well at the end of the day, who are trying to solve the puzzle, get through all their patients in a day, and juggle a handful of other things. And so one thing that I did recently is I actually invited my hematologist to our upcoming walk that we have over here in Florida, the Unite Walk. And so I feel like, trying to sometimes make our human connections, right? Obviously, you're in an appointment and you're there for business and you want to get the answers you need, but trying to find the humanity in one another, including your providers, I think can go a long way. And luckily, my hematologist has been super, responsive to that, and is hopefully will be coming out to the walk with her family as well. But I think sometimes it's helpful for them to see us outside of that confined patient room as well. And that brings me to the question I wanted to address that Steve put in the chat of, quote, "We need to address the use of factor number as dispositive when clinical presentation is the proper criterion." I can definitely relate to that as someone who's mild, right? My levels may jump, but it doesn't automatically disqualify all the pain and the range that it can jump to. And then I'll kind of just put Steve's question, and then I have one more question before we go to like the actual Q&A from the audience. But Steve also said, to Dr. Johnson's point, does ASH have a list of hematologists to whom HTCs and chapters can reach out to? if we don't have an answer for that right now, we can just move forward. And if anything, Steve Long was the person who asked that question, so maybe we can connect afterwards. But my remaining prompted question, and then we'll move on to the actual Q&A, is really just for community members asking, what advice or support would you offer to others who may be experiencing these challenges, and what can the broader bleeding disorder community do to support these groups?
Well, I think one of the things, when we're looking at these different groups and looking at how we can continue to support them, is that many times many of the chapters themselves don't have the manpower or just person power to be able to create some of these programmings. So I think one of the biggest things is that as we're working on something, is being able to share what were your successes, what were some of your challenges, what were some of the barriers, and be able and be upfront with that, the good, bad, and ugly, basically, so that when people are starting to create programming like this or programming that is needed throughout, they have a springboard and they're not starting from square one. Um, like we said, Mosey and I are really trying to work and create some type of toolkit as we have this, the panel discussion, having it be less than an hour so that people could see it during their lunchtime was kind of step one. How can we create something that may be virtual or in person, and then kind of continue some of the momentum there, then start sharing it with other chapters. And I think one of the biggest things is just learning and listening to what others are going through or what other chapters are also asking and adding to it. I think that's one of the best things that we could do. Yeah, and it is sharing best practices. That's one of the best things that we could definitely do, as opposed to everybody starting from square one, because we do not have the time or the personnel to be able to do it, to be honest with you.
Yeah, I totally agree. We've done that here in Ohio. We have 4 chapters here in Ohio, as most of you know. And so we've got a really good, strong network between us. And so, yeah, we've shared our list, we've shared our emails that we sent, we've shared all of our educational resources that we used, and we've shared it with the other EDs that you can just take this and run with it, right? You can pick up where we've left off and you can send it out to all of your providers. So it's really, everybody wins if you share what the work you've done, and then somebody else may build something that you haven't even thought of moving forward. So I think everybody wins in that situation.
Absolutely. I think that's something we've actually been talking about in Blood Sisterhood and Brotherhood as well, how sometimes, even though people have very different experiences, there's overlap in the techniques and the strategies that we use to get the answers that we need. And sometimes it takes asking my brother how his experience was, or some of the older women in Blood Sisterhood, to really understand, okay, this is not something that has never happened before. And even though their experience was maybe a little different, there's something I can learn here or that can be applied in a different way. So thank you to everyone. And let's hear from the audience. Ray, do we have any questions in the Q&A? I think I saw a few.
Yes, we do. Thanks, Salemi. The first question: since bleeding disorders are in most cases genetically linked and with the significant impact on menstrual cycles, childbirth, and beyond, should treatment and care be more female focused than male focused, as it has been in the past? It seems the presence of severe symptoms in males are a proverbial canary in the coal mine for an underlying genetic predisposition for familial incidents across men and women, while women receive far less treatment because their symptoms are less obvious or visible.
I completely agree with that statement and question. I wondered if Dr. Johnson would want to answer that from coming from the clinical background.
Yeah, I would love to. I'm trying to give everyone their space because I'm just so excited to hear what everyone has to say. So from my perspective, yeah, so I have a genetics background, so I completely agree with that perspective. And when we come to clinic, both as providers and to try and do research that makes things better, I mean, I really think we have family clinics these are family clinics with multiple people at risk. And because the males are at risk and the females are at risk. And so everyone who has the opportunity to inherit that genetic change, or sometimes they're showing up and they're the first one in the family with that genetic change, we have many other people who are potentially at risk. It's an opportunity to, if we can see all those at risk and approach their care needs and their diagnosis needs, but then also they're the key to the rest of their family risk and all those other people that might be out there that haven't been there, understood that they had a risk for bleeding or didn't realize that their bleeding was abnormal or there's other things. So I think when we approach the whole family, I think that that's the key. And I do agree that sometimes female bleeding can be the harbinger. Like we find them in the OB clinics or find them from their postpartum hemorrhage, or they're in the adolescent clinics, and just not places that have been connected to something that's called a hemophilia treatment center that was really geared towards male bleeding at the beginning. But I'm interested to hear what everybody else has to say.
I think to add to that, just some changes, some positive changes for the better in our community with the ISTH nomenclature related to women with bleeding disorders, and just kind of going off our project name that women bleed too. Women can have hemophilia. Women just aren't just carriers. They can have hemophilia. And then my understanding is the American College of Obstetricians and Gynecologists also redefined heavy menstrual bleeding. And Dr. Johnson, you might be able to talk about that more, but that is a step in the right direction too, of, this just bringing more awareness among providers.
Yeah, it feels like the ice is really breaking, like on multiple fronts, across disciplines. And I think this is the time to have this intersection of community and the professional spaces work together to take advantage of that momentum. Definitely OB and GYNs are recognizing and redefining more what is really not normal, and looking at more systematic, like more defined systematic ways to approach it, which includes defining bleeding disorders, but also all the other reasons that someone might have bleeding. And in hematology, I think this is a really wonderful time to also address these, where female issues across hematology, we see this in our professional spaces, are now coming to the forefront. So the time is right for this kind of opportunity. Speaking to the rural aspect of our summit, I again think that this is where representation really matters, because we can't, as Mosey was saying, like if we don't know about it, we can't make it better. And then when we learn that, we need to be humble and listen and figure out why did we miss it and how can we fix it.
And there is a question that came up in the chat, Dr. Johnson, directed towards you. Out of curiosity, is there a cost savings opportunity in seeing the family in an appointment in addition to improving diagnosis and care?
Oh, that's an interesting question. So I can say, I think there's a cost savings when people have the right diagnosis and get the right care, but that's that may be controversial when treatments are expensive. Family dynamics are complicated. So just because we're related by blood doesn't mean our hearts are related in the same way. And so I think that that's an individualized thing. We certainly have families that all come together. One important thing is that every individual in that family gets individualized and private care, because we want to make sure that we're able to hear everything and be able to take care of them. Yeah, I think connecting with families can be a wonderful resource. I think as a system, we have to remember it's a group that's comprised of individuals that each warrant their own diagnosis and their own care at the same time. So it can improve efficiencies. I don't know if it improves cost.
Thank you. And then we've got one more question in the chat, Noemi. and that is a question that we've kind of bounced around answering. But I think more specifically in the data across CDC and HTC's member organizations, there's a significant disparity between diagnosis, awareness, and reporting between ethnic backgrounds. In your view, what are the biggest causes for this, and what are the biggest areas of improvement that could see positive change?
I think one of the things with this is that many of the community members receive their care in different locations, and depending on where they're receiving their care is how closely they're willing to work um, with not only HCCs but with the chapters, and I think that the CDC. There are different reportings that take place, nationally that have to be done. For a lot of this, I'm not sure if a lot of the bleeding disorders are one of the ones that must be reported on an annual basis with one of the reports. But even working here in Southern California, we have Kaiser Permanente, who does not want to work with us because they feel that if they work with us, they have to support us financially. And that's something that we're trying to break through, but then we have other hematologists that are smaller in smaller rural areas, and they may not even know that we exist. And so that's one of the things that we're trying to get across is how can we continue to do this, not only so that we get the numbers, because that's by no means, um, doesn't change what we're doing. But I think one of the biggest things is that if we're able to really know about these numbers, we're able to see where are the population clusters and what are those clusters. We hear that there's a large von Willebrand's community out in Southern California, but this is coming from a hematologist, and when we ask, can you share that information so that we can provide services, they're like, oh no, that we're good. you know um and what ends up happening is that the community is affected by it, not the treatment centers, not the doctors or ourselves, to be included in that matter.
I also wanted to add to that point because it actually reminds me of a conversation we had at the NVDF Health Equity Summit, which actually I believe Riga was also there, yeah, in New Orleans earlier this year. And so there's a few things. I think for one, obviously there's not enough people of color or marginalized communities that are sometimes aware of the opportunities to provide data. And sometimes even then they are hesitant for whatever cultural implications or historical implications as well. I mean, for me, for example, I'm Puerto Rican. We have a history of being tested on medically. The birth control pill, right? That's because of the testing, non-consensual testing that was done on that population. We also see with the African American community, right? The Tuskegee experiments, and also Native American communities have their own, complications with wanting to sometimes go beyond the reservation and the medicine that they know to work for their communities. So I think that's something to consider, right? It's not always an element of people not wanting to or not knowing. It's a combination. And as a response to that, I think, or also gender roles sometimes play a huge factor in my community as a Latina. But I think creating safe spaces, empowering the voices in your community that you maybe aren't used to amplifying, and kind of like Mosey said earlier as well, allyship is super important, and considering how different communities communicate and how they receive their information as well, I think is key to not only engaging that community, but letting them know that that data or opportunity to be part of the data is out there as well. All right, and if we have any last questions, this might be the final call to put some questions in the chat. I don't think we have anyone else as of now. Maybe I'll give another minute. I don't know if anyone else wants to add something.
Yeah, so while we're waiting to see if there's one more quick question. If the CDC is doing surveillance study, they can only go where they know the people are. So almost all the surveillance is through HTCs. So I think a lot of the biases we see are related to who can access an HTC and then who can participate in surveillance or agrees to participate in surveillance. And though I think that many know, but maybe not all know, that data informs so many things about how federal and state resources are sent to support the community. So similar to participating in the census, being in surveillance
I was
data
just gonna
is really important.
Yeah.
And although there are many challenges, the barriers are just higher for people who are in a rural area or in another marginalized community or population, and we need to figure out how to make it more equitable. That is what that data is important for.
Absolutely. Love that. Definitely ask your HTCs or your orgs about any, studies they might be aware of. You never know until you ask, right? It seems that that's all our questions for this panel, but I want to thank our panelists and our audience for such a great session. And I definitely have taken many notes myself. So thank you everyone for your insight.
Noemi,
you.
thank you so much for facilitating this session. Thank you to everyone who is part of this conversation. I will say that without bearing the lead, a lot of what you've just talked about was certainly presented and reflected in some of the earlier conversations today. And it's clear that as a jumping off point, there's an opportunity to continue to have conversation, especially with folks around the table who weren't part of this conversation, to be able to continue to shed light from all points of view about filling in gaps, so to speak, about identifying solutions to bridge, unmet need with need, and all of that being done with consideration of both disease-specific barriers, but also broader universal barriers that exist around sort of existing in these systems that we do. So HFA is dedicated to continuing to work along stakeholders. We certainly want to thank again the sponsors that have allowed us to continue to expand our health equity work, which is really about community engagement from all corners of our country. Thank you to Genentech, Sanofi, Takeda, and Bayer. Thank you very much to a working group who have not been recognized during today's summit, but a working group of many of you who shared your expertise as presenters and panelists and beyond, who had conflicts and weren't able to share the work that you're doing. So if you are listening to this call, know that continuing this work around barriers to care within communities of concern in particular is a dedicated project for HFA that will be leading in 2025. And we are open to ensuring that if we need to pull up another chair, we'll grab one from the other room. So we're looking forward to continuing these conversations very much. I just want to celebrate, first of all, that we are early, which is very exciting. Great work, everyone. I want to recap before I let us all disconnect. These were our objectives today: to have collective conversation. We've already identified spaces to bring more folks to the table. We wanted to understand what's being done. We got a really great presentation in session 2 about what's being done through HTCs and through Athens, and collecting data to be able to understand what are the barriers and learn some things that I think we didn't expect. Like, it's not just about the distance that prevents patients and consumers from presenting for regular care. We also learned about the work that's being done by the community organizations that are on the ground, like Rigo presented, for example, about what's being done to really understand the community well. And then exploring these unmet needs is where we propel ourselves in the work for the coming year. Very important. We have recorded this summit today. We plan to offer it either in clips or in full, depending on what our capacity is to send it out. But we certainly need anyone who participated today to share your feedback. Please look in your inbox for a survey. I know these are things that we often don't want to do, whether it's the drive-through or the grocery store or getting off the phone with a with a customer service representative, but I'll tell you that without your feedback, we can't properly represent what the community needs and wants. And we also want to know how to keep the best and leave the rest, so to speak. If this platform allowed us to connect a lot of folks in one space in an affordable way, we want to do that. But if it eliminates the chance to be more engaged with each other, we want to consider that as well. So I need you to please look in your inbox for a survey and know that we want to hear your feedback, and our commitment is to make completing that survey really easy. So I promise you that. Resources, of course, are really critical from today's session. So we'll be sure to collect everything that was shared from our great presenters and our fantastic participants that were in the chat. These are some that you can go to right away. Among many other important websites, there's ours, HFA's website, hemophiliafed.org, where you can search for HTCs by state. You can find an organization near you, and you can look at our calendar of events that are coming up that were promoted during today's conversation. So thank you all very much, and we're very much looking forward to doing more work together in the coming year. Take care and be kind.